go together with even those peripheral nerves. And it is the most complicated in the diagnosis for pathology practice. It is a challenge. So for the soft tissue, the origin is the mesenchymal proliferation that occur in the extraskeletal non-epithelial tissue of the body, excluding the viscera covering the brain and the follicular system. The soft tissue may arise in any location, but most 40% occur in lower extremities, especially thigh, 20 in the upper extremities, 10 in the head and neck, 30 in the trunk and retroperitoneal region. This is an epidemiological overview. They say the larger, the poorer the outlook. More superficial, the better the prognosis, meaning that when it is superficial, it has a good prognosis. When it is large, it has poor prognosis. So as the other tumors, after diagnosis of soft tissue tumor, you have to give the grade and the staging. For the soft tissue, there is histological grading specific to the soft tissue. And also there is a staging of soft tissue, both to get the treatment and the prognosis. For example, you can have some histological type, for example, adipose tissue benign, you can have lipoma, malignant liposarcoma. Fibrous tissue, you can have fibromatosis and nodular fasciitis. And when it is malignant, it is fibrosarcoma. This is what we call fibrostic tumors, can have fibrostic fibrous osteostoma or dermatofibroma. Whereas malignant, you can have malignant fibrous osteostoma. Skeletal muscle, the benign is labdomioma, and the malignant is labdosarcoma. Smooth muscle, benign is called leiomyoma, malignant is called leiomyosarcoma. Vascular, a benign tumor of vascular tissue is called hemangioma for blood vessels, and lymphangioma for lymphatic vessels. And when it is malignant, it is called angiosarcoma. Peripheral nerve, I have seen it in neuroanatomy. You can have neurofibroma or schwannoma. And you can have malignant peripheral nerve shift tumor. It's what we call uncertain histogenesis, like what we call granular cell tumor. And those when they are malignant, we call synovial sarcoma, alveolar soft part sarcoma, and epithelioid sarcoma. The cause of the soft tissue tumors is unknown. You can have some, they say, some chemicals like burn, heat burn, or trauma, or other chemical products like phenoxyherbicide and chlorophenols has also been implicated in the pathogenesis of the soft tissue tumor, but the cause is still unknown. There is what we call Kaposi sarcoma. Kaposi sarcoma, this one, it is found in immunosuppressed patients, most of them HIV patients. Is related to herpes 8 virus. If you have done your biology, you have seen it. It is the main cause of those Kaposi sarcoma. We are going to see those images of the Kaposi sarcoma because in your clinical practice, you will meet some cases of Kaposi sarcoma. But if this an introduction of HIV treatment, there is reduction of those incidence of those Kaposi sarcoma. But before the treatment of HIV, there was so many cases of Kaposi sarcoma. He says some soft tissue tumors occur sporadically, but a small minority are associated with genetic syndromes. We have seen in general pathology that there are some genetic factors in pathogenesis of tumors. This, for example, those Neurofibroma, those malignant Sonoma, those fibromatosis, there are some genetic factors related. But now it is not the time because it is very long. What you must know is that some soft tissue are related to genetic factors and some mutation in those tumors. So the problem in diagnosis, it is very difficult to agree on histogenesis of those tumors. Some sarcoma have multiple cell types in different areas. Many tumors are also undifferentiated. That subclassify them into the histogenic type, which is caused to impossible evidence-based techniques such as electronic microscopy or immunohistochemistry, meaning that the diagnosis of soft tissue and their classification, it is not easy. Most of the time, you have to use immunohistochemistry and electron microscopy. This one we have said after the histological type, we have to give the grade and the stage. There are some tumors known as high grade and low grade. However, some of the soft tissue sarcomas are very differentiated. But like those liposarcoma, myxoid liposarcoma are always low grade, whereas abdominal sarcoma, synovial sarcoma, mesenchymal chondrosarcoma, and extraskeletal sarcoma, those are always high grade. American Joint for Cancer Classification developed the clinical staging system that depends on primarily on the grade and the size of the soft tumors. This one we see them in practice. So this is how American Joint Cancer Classification, they say about the primary tumor, lymph node, and distant metastasis. This one, it is general, I have seen it in general pathology. They say T1 tumor inferior to 5 centimeters, T2 inferior to 5 centimeters, N0 no regional metastasis, N1 lymph node metastasis, M0 no distance metastasis, M1 distance metastasis. But remember that those metastases here can be done through the radiodiagnostic. Histologic, we have seen in general pathology, well differentiated, moderately differentiated, poor differentiated, what we call high grade, and undifferentiated. And undifferentiated, we don't even know the origin. Sometimes you have to use those immunohistochemistry, where you use the vimentin and desmin antibodies to know if they are from fibrous, if they are from muscles. This is the American Joint Cancer Classification for soft tissue sarcomas. So for other tumors, like other tumors, you can have benign and malignant tumor. For example, when you go to adipocyte, lipoma is the most common, and there is liposarcoma. Lipoma is the most common soft tumor of the adipocyte tissue. They said age between 40 to 60 years. The most common site is subcutaneous region, and it is encapsulated and small. Lipoma are soft, mobile, and painless, except what we call angiolipoma. This angiolipoma, it is mixed with adipocyte tissue and blood vessels. The distribution, most common is the upper back, neck, shoulder, abdomen, even little peritoneum. proximal extremities, buttocks, and the upper thigh. Layering can be found in the face, hand, or feet. But in general, lipoma can be found in every tissue. On the gross, it is soft, well circumscribed, and encapsulated. Round, it is about few millimeters. Most of the time, around 10 centimeters. This is an image of the lipoma. This one here is fat. This one is a connective tissue around those fat, where there is blood vessels and fibrous tissue. This one white. Whereas this one yellow, it is completely fat. There's some type of the liposarcoma, what we call pleomorphic liposarcoma. Those they have some mutation, but they should not be mistaken for liposarcoma. This is an image of this lipoma. We have seen the benign is lipoma. There's also liposarcoma. But what you must know, it is difficult clinically to say this is lipoma, this is liposarcoma. You have to use a microscope histological analysis. And the most characteristic of liposarcoma on the image is the presence of fibroblasts. This one mimic fetal fat cells. What you must know is that sarcoma found lipoblast. Whereas in the lipoma, we don't found the lipoblast. Liposarcoma histologically can be divided into well-differentiated, myxoid, round cell, and pleomorphic variant. For example, this one is a liposarcoma, closing on the tibia region. Most of the time, liposarcoma is bigger than the lipoma. This one is the atypical adipocyte cell known as lipoblast. This is a characteristic of liposarcoma. Once you see this image on the microscope, immediately you confirm it is liposarcoma. Then you go for those type of, if it is well differentiated, round, and the pleomorphic variant. This one is the well differentiated liposarcoma. This one you can confuse it with the lipoma. This was, have to pay attention on it. This well differentiated tumors of extremities recur and around 50% fluid cause death. Poor differentiated or retroperitoneal often occur and metastase to the lung, bone, and they have a 5-year survival of 20%. The treatment is chemotherapy, surgery combined with chemotherapy and radiotherapy. Fibrous tissue. Fibrous tissue, the most common is what you call nodular fasciitis, Peripheral fibromatosis, and abdominal fibromatosis. This one is common. A desmoid tumor. You will see a patient with the abdominal wall mass. Most of the time it is round. Most of those tumors, they are called abdominal fibromatosis, and they are desmoid, and they are benign. They are what you call fibrosarcoma. Let us see the nodular fasciitis. It is self-limiting pseudosarcomatous process composed of fibroblast and myofibroblast.
Because
most common lesion is diagnosed as sarcoma.
is the
It is rapidly growing, large cellular, and sometimes they say it is related or trauma, but we are not sure. The signs: rapidly growing solitary mass, lesion over 1 to 2 weeks, open at the site of the previous trauma, but it is not a rule. 50% of the lesions are painful. Can have some numbness, some paresthesia if compression of the peripheral nerve. Most of the time it is around 20 to 40 years, but it is not a rule. You can even find it in young. Anatomical distribution, it may occur anywhere in the body. Through the prediction of upper extremities, chest, back, head and neck, and lower extremities. Can found on hands and feet, what is uncommon. Head and neck, most common in children and in infants. Grossly, it is very circumscribed, non-encapsulated. The lesions are less than 2 centimeters. They can be divided into subcutaneous, intramuscular, and fascial subtype. Microscopic findings, what you see is the proliferation of fibroblast and microblast in short regular bundles. Stoma fibrosis. Fibrosis, remember that is an increase of fibers. This is the nodular fasciitis on the microscope. You can find some lipid-filled macrophage and some giant cells. For example, this one, you found some lipid here, and this one, proliferation of the fibrous tissue. This one is the proliferation of the fibrous tissue. Another one, and common, is called fibromatosis. Superficial fibromatosis can find the palmar, plantar, and even on the penile. Palmar, plantar, and the penile fibromatosis, more bothersome than serious lesion, are a group of called superficial fibromatosis, characterized by nodular or poor-defined fascia of mature fibroblast surrounded by dense collagen. Immunohistochemistry and electron microscope can indicate these cells are fibroblasts. The most common is the Petrel contracture and plantar fibromatosis. Benign fibrous tissue, this one, the Petrel contractures has proliferation of fibrous tissue. They say more common in Northern Europeans and rare in blacks, but even in black is found. It has some genetic component. It is associated with unrelated disease and social behavior. Type 1 and type 2 diabetes mellitus, epilepsy, alcoholism, hypercholesteremia, cigarette, and manual labor. Plantar fibromatosis, it is slow-growing nodule on the hand, progression to fourth, band with contractor of fourth and fifth finger. So this is what we call the Dupuytren's contraction. This is an image where we have the immature fibroblast with uniform appearance and no mitotic activity. These are the fibrous tissue. This is during the operation where they are reducing the Dupuytren contraction. This one is done in a surgery. Abdominal fibromatosis or abdominal desmoid tumor, locally more aggressive than superficial fibromatosis. high recurrence. They say previous trauma, but it is not a rule. Some patients with the Garden syndrome, which is the autosomic dominant chronic polyposis, these are those genetic factors. They say also about the estrogen, but we're not sure. Grossly, it is poor circumscribed tumor. Microscopic, it is proliferation of spindle cells in bundles surrounded by collagen and limited mitosis. Treatment is surgical excision. Recurrence is around the 15 to 30. You can also some use the local radiation, but most of the time surgical treatment is enough. It's what we call deep fibromatosis. This one lies in the interface between exuberant fibrous proliferation and low-grade Fibrosarcoma. On one hand, they prevent frequently as large infiltrative mass that may occur after a complete excision. So it is like those, they are between low-grade and high-grade Fibrosarcoma. So Fibrosarcoma, those that are very rare. Most of the time, those soft tissue are benign. It may occur in the body anywhere, but mostly in the retroperitoneum, thigh, and distal extremities. The sign and symptoms: solitary palpable mass bigger than the lipoma. It is about the age is about 30 to 50 years. It can also found in the infant type, first years of life, and sometimes even congenital. Don't be surprised if they found congenital fibrosarcoma. Anatomic distribution, other type they found soft tissue of all extremities, head and neck, lung, heart, liver, and central nervous system. In children, it is in distal extremities. Grossly, it is solitary, lobulated, circumscribed, frequently encapsulated, and invade adjacent structures. And even invade the bone. This is an image of those Fibrosarcoma. In the practice, we see those description of those Fibrosarcoma. Fibrosarcoma prognosis, it can have local recurrence, the rate of 50%. Survival rate, 5 years. The other type, it is about 8%. Infertility, it is 8%. The treatment is what? Surgical excision, radiotherapy, and chemotherapy. There are other tumors called tumor condition of fibrostic origin. Though they have histiocyte. The benign one is called dermatofibroma, and the most common. Intermediate is the dermatofibrosarcoma protuberans, DFSP. And then malignant fibrous histiocytoma. These are common in our settings. Benign fibrous histiocytoma, we can have some solitary, they are solitary slow growing nodule of the skin. Age, they say young adult around 20 to 45. Prognosis, simple surgical excision. This one can be treated with simple surgical excision. Let us see the image of that dermatofibroma. But when you see this on the skin, you can't know the diagnosis. It is better you do the biopsy. Dermatofibromas protuberans is slow growing, non-painful tumor. They say antecedent trauma in 10 to 20%. They are found in younger than dermatofibroma. Anatomic distribution of those DFSP is trunk, groin, proximal extremities. Whereas this one, benign fibrous tumor, it is most common in the distal extremities. Whereas this one, it is on proximal extremities, but it is not a rule. This is the solitary mass of subcutaneous skin. The average is about 5 centimeters. It is what we call marginal fibrous osteostoma. Most common sarcoma of late adult may occur secondary to previous radiotherapy. Radiotherapy also is not good. It can also cause some tumor. It is painless, larging mass, retroperitoneal tumors, fever, and leukocytes. Anatomic distribution, it is lower extremity thigh, followed by upper extremities. On grossing, it is solitary meteorite fresh masses. Here it is the difference between the Fibrosarcoma and the malignant fibrosteostoma. But this one, for you, it is not differentiate. This is for an experienced pathology. For you, what you must know is that Fibrosarcoma distribution in the prognosis and the treatment. They say Fibrosarcoma, it is equal in male and female, whereas fibrous osteoma, it is more common in male than female. Fibroblast is herringbone pattern. This is what we're going to see them in practice. Whereas fibrous osteoma is fibrous in storiform or star pattern. Moderately well differentiated, whereas this one is poor differentiated. No giant cells and found histiocyte. Whereas in histiocytoma, it is multinucleated giant cell, neoplastic appearing histiocyte. Fibrosarcoma, it has better prognosis than malignant fibrous osteostoma. So now let us see the tumors of the skeletal muscle. This one, it is very easy. Skeletal muscle, there is abdomioma and Fibrosarcoma. Fibrosarcoma, most common soft tissue of sarcoma of children under 15 years. Clinically, tumors in the head and the neck can present with cranial nerve signs. In the genitourinary tract can be found dysuria, hematuria, or incontinence. Tumors in extremities present with painful, rapidly growing mass, predominantly in infant and children. Anatomic, I've seen before, head and neck, genitourinary tract, upper and lower extremities. So those of the sarcoma, they have also some subtype. There is what we call botuloid embryonal tumors of bladder and the nasopharynx are polypoid mass with hemorrhagic gelatinous cyst. Tumors of extremities are usually solid and gray-white, about 3 to 4 centimeters. This is an image of those Labdomyosarcoma. Labdomyosarcoma histologically is classified into embryonal, alveolar, and some pleomorphic variant. And the most characteristic is the labdomyoblast. The diagnostic cell in all type contained eccentric eosinophilic granular cytoplasm rich in thick and thin filament. Labdomyoblast Fibroblast may be round or elongated, also known as tadpole or strap cells. These are those abdominal blasts, even here. This one is alveolar, this is embryonal abdominal sarcoma. So now currently they survive for 5 years for botryoid embryonal abdominal sarcoma is 95%, embryonal abdominal sarcoma 6%, and alveolar abdominal 50%, 54%, and the metastasis in 20% of cases, commonly in lung, bone, and lymph node. So don't be surprised when you have abdominal on the lower limb, then you found some metastasis in the lung. Tumor of the smooth muscle, this one we know, benign is called Hemangioma. Malignant is called Fibrosarcoma. The benign smooth muscles, most of the time they are found in the uterus, can also found in the skin. But most of the time we found it is uterine Hemangioma. Fibrosarcoma, they are not common. Most of the time they develop in skin, deep soft tissue of the extremities, and retroperitoneum. Fibrosarcoma of the uterus are not common. This is a benign tumor of the soft tissue, the Hemangioma, and this one it is on the uterus. It is the Hemangioma on the uterus. This one. Tumors of the blood vessels, when they are benign, they are called hemangioma, and when they are malignant, they are called angiosarcoma. The hemangioma, they are most common benign soft tissue in infants and childhood. They are painless blue red nodule. The direction of those tumors is the head and neck, and some internal tumor of the liver in adult. This is an image of the hemangioma. This one round, it is a blood vessel. You see the blood inside, and there is an increased number of the blood vessel, what we call proliferation. And here around, they are supporting connective tissue stroma. But what you see, the most common is proliferation of blood vessels. This is what is called hemangioma. Angiosarcoma is rare. Chronic lymph. It is before this chronic lymphedema, previous radiotherapy, predisposed to angiosarcoma. Clinically, it is early defined bruise with indurated border. It has edema, ulceration, and necrosis. Anatomic predilection is on the skin and superficial tissue. Prognosis is poor. It has metastasis to the lung, liver, spleen, and lymph node. A tumor of those peripheral nerve tissue, most common is called schwannoma, also known as the Neurofibroma and Neurofibroma. A malignant is called peripheral nerve sheath tumors. Schwannoma, they are most common. They are free, mobile, non-painful lesion. Anatomic distribution is the head and neck, flexor surface of the upper and lower extremities. I hope you still remember the anatomy. This is an image of those schwannoma. This one. This is an histological images of this schwannoma. We are going to see in practice, what the characteristic, what we call verrucous bodies, characteristic of Sonoma. Neurofibroma, it is a growth pattern that may be localized, diffuse, or plexiform. It occurs in the setting of those neurofibroma, also known as von Requesens disease. It is localized in tumors, in sporadic, and not associated with localized tumors are not associated with Neurofibromatosis 1, whereas diffuse and plexiform are associated with the Neurofibromatosis. Neurofibromatosis type 1. This is an autosomal dominant with penetrance, and it is found with 50% with the new mutation. Clinically, this is what we call café au lait spots. Café au lait spots. They are characteristic of those neurofibromatosis type 1. Multiple neurofibroma involves the skin, GIT, larynx, blood vessels, and heart. Some central nervous tumors like aortic glioma and astrostoma. Some symptomatic pigmentation of the iris, what we call lymph nodules. Skeletal abnormalities in 40% of cases. They can have malignant transformation less than 4%. Sign and symptoms, they are slow growing, painless nodules found in around 20 to 30 years, and they are found in damage through the body. Malignant peripheral nerve sheath tumor, it is also found with the neurofibromatosis 1. Anatomically, it's associated with major nerve trunks like sciatic nerve, brachial nerve, and sacral plexus. Closely, there is centric mass with hemorrhagic and necrosis. Malignant peripheral nerve sheath tumor, if associated with neurofibromatosis patient or tumor arising in anatomic component of major nerves or contiguous neurofibroma, this one recur local. In distance, metastases are frequent. Plexiform variant in children has better prognosis. Growth is large mass producing a fusiform enlargement of a major nerve, most of the time of the sciatic nerve. There are other tumors called primitive neuroectodermal origin. These are what we call Ewing's sarcoma, associated with the primitive neuroectodermal tumors, like those endocrine tumors. It is known as Ewing's sarcoma. Closely, it is related to those malignant known as the small round blue cell tumors, Ewing's sarcoma, the Fibrosarcoma, Neurofibromatosis, and the others. It has the genetic factors, translocation, the 22. Tumors, those primitive neuroectodermal tumors. Ewing's sarcoma, it is rapidly growing, found in young adult, most of the time inferior to 30 years. They are located in extremities, upper thigh, buttocks, and shoulder. Extraskeletal Ewing's sarcoma usually arises in paravertebral areas in association with the vertebral or lips. Most common in children of 10 to 15 years. They say black are rarely affected, but we have seen some cases here in Rwanda. It is the most common bone sarcoma in children. They rise in the medullary cavity of their feet. They affect long tibial bones, especially femur, flat bones of the pelvis, invade the cortex, and penetrate the periosteum to produce a soft tissue extension. Clinically, Ewing sarcoma is painful, enlarging mass, warm, swollen, suggestion of infection. The periosteal reaction produces layers of reactive bone deposit in onion skin fashion. On the radiograph, combine the radiation and the chemotherapy. Sorry, the treatment is about the radiotherapy and chemotherapy, and survive is around 70% for 5 years. So this is an image of extraosseous Ewing sarcoma of Denis of 26 years old male. This is an image also of the Ewing sarcoma. This is histologically, it is a sheet of uniform small round blue cells. It has what we call home-lythocellular scant cytoplasm, which often contain glycogen, fibrosarcoma, prominent necrosis, and it can metastasize to other bones or elsewhere. And certain type of tumor is synovial sarcoma on the joint. Synovial sarcoma is usually a deep-seated mass present for years around the joint, knee, and ankle. This one, it have two types. It can have fibrous and epithelial cells. This is why we do some immunohistochemistry, what we call keratin. This one, when they're positive, immediately you have the epithelial component, and it has a favorable prognosis. They say tumors detected in peripheral blood monocyte in one case by PCR. It has also some genetic factors. It may occur locally and metastasize to the lung and pleura, bone, and lymph node. Poor prognosis factors of those synovial sarcoma, it is high serologic grade. Based on these proliferative indicators and necrosis associated with lung metastasis. There's also some gene mutation. Treatment is local excision and radiotherapy. Grossly, it is very circumscribed, firm, gray pink, some calcification in the X-ray. Layered can affect major nerves. This is an image of the synovial sarcoma. You see here some epithelial cells, and around there are some fibrous tissue. So in summary, for soft tissue, most of them they are benign, on duration 100/1. They are aggressive if they are malignant. Always coordinate with clinical or pathological findings and work together as multidisciplinary team. Multidisciplinary team here means a physician, radiologist, pathologist, and the oncologist. They meet together, what we call a tumor board, then they discuss on the diagnosis. This is why they call it multidisciplinary team. So this one is the reference a reference book. It is called Nzinga Soft Tissue Pathology. This one is the most common for pathology, Nzinga. Even in Lozai and Robin, you can find those soft tissue, but the specific book for soft tissue is called Nzinga. So before we go to some images, any question about the soft tissue? Any question? Any question about the soft tissue? Any question? Any question?
There is no question.
No question?
Yes.
If there's no question, I have shared with you some links about the soft tissue. There are several types of soft tissue. We see here on this web pathology. Here we see on the fibrous tissue. We see nodular fasciitis, proliferative fasciitis, cranial fasciitis, ischemic fasciitis, keloid, desmoplastic. Those are tumors. You can find them. Fibrocytic variant, juvenile xanthograma, xanthoma, giant cell, those are tumors. We go on the lipoma, lipoma, and what you must know for everyone, it has its specific image. When you go for the myogenic, these are tumors. Vascular, peripheral, and certain histogenesis, miscellaneous soft tissue, like those tumor calcinosis. So you see now it is a very big, and you can't memorize in a short time of 2 months. Because this one is even in the pathology, it is a subspecialty. After general pathology, we do subspecialty of soft tissue, because as you see, the disease so many, and each disease has image. This is why it is a challenge in the diagnosis of a soft tissue. Since we have to make someone specialized only in soft tissue. But for you, you can keep some common images, like this one. Nodular fasciitis, because those are the most common. For example, this one. You see proliferation of the fibrous tissue, you see some vessels. Another one common, desmoplastic fibroblastoma, but this one not totally common. Fibromatosis. Like this one, desmoid tumor. See those fibroblasts? And on the grocery, it is like this. When you found this muscle on this tumor on the abdominal wall muscle, most of the time you can think about the desmoid tumor or fibromatosis. Another one common in the fibrous tissue is the Fibrosarcoma. This one is a malignant. You see now, there are so many images of this, but the most common is this one. Here they say grading of Fibrosarcoma is done on the basis of degree of severity in differentiation, mitotic figure, and necrosis. This one you must keep in mind. Grading of Fibrosarcomas is done on the basis of degree of severity, differentiation, mitotic activity, and necrosis. When there is necrosis, there is a poor prognosis. Mitotic figures and necrosis, they are indicators of poor prognosis. Histiocytic, you can see this one. Fibrous histiocytoma. These are some histiocytic cells. Form histiocyte, this one, whitish, like this one. These are those histiocytes. Form histiocytes. This it is in the case where it is benign. Let us see an image where it is malignant, like this one. But this one is still benign. Dermatofibroma, Fibrosarcoma protuberance, this one is common. You see how it looks on the skin. This is the fat, this is the skin, this is the tumor. This one was about the fibrous. Let us see the lipoma. example, an image of lipoma. For example, this one, this is what we call lipoma, giant lipoma. After surgery, it is like this. And the image, it is like this one. But this one, it is also associated with the necrosis, what we call fat necrosis. These are adipocyte, these are infiltration of lymphocyte. Angiomyolipoma. No, it is not. Sorry, pleomorphic lipoma. You see those images? Myogenic, let us see the leiomyoma. This is an image. Please do not disturb. Please unmute yourself. This is leiomyoma with a myxoid material. This one is gelatinous material. This one. And this one is muscle proliferation. This one is an image of this one. Whitish here is the myxoid material. This one is the muscle. Vascular, let us see the hemangioma. This is the lobular capillary hemangioma. This is an image of lobular capillary hemangioma. For hemangioma, you can have capillary hemangioma and cavernous hemangioma. Lobular, it is when they have, sorry, cavernous is when they have large blood vessels. Capillary, it is when they have small blood vessels. For the peripheral nerve, let us see a schwannoma. This is how they appear after an operation. This is an image of the schwannoma. What they say, they are composed of cellular Anton A areas alternating with hypocellular areas B. Antonia A areas are composed of interlacing bundles of spindle cells. This one. with wave or oval nuclei. Eosinophilic and distinctive cytoplasmic borders. The Anton areas show pulsating wall pattern and verrucous body that formed a high-ordered arrangement cells. Verrucous bodies. Let us see Anton B. Anton B areas are hypocellular and less compact than Anton areas. They consist of hazardous arrangement spindle cells in loose myxoid stroma, like this one. We see them in the practice. Another one I have to show is the Kaposi sarcoma. This one you must know. And this one is clinical image of a Kaposi on the rectum. This is an histological image. Kaposi sarcoma is caused by the virus herpes 8 virus. Another image you must see is the Neurofibromatosis 1. You see the image of those neurofibromatosis. 1, the image of cafe or spots. So you must keep in mind this image, cafe or spot. These are neurofibromatosis. So in your clinical practice, you meet those people with those cafe or spots. There's some tumors called myxoma. They have the myxoid material, like this one whitish material. Is what we call tumor carcinosis. This one has calcified material. Like this one.
Excuse me, lecture.
Yes.
About neurofibromatosis 1. Nibyo mu Kinyarwanda bita ibihara.
No. Don't go into those terms of Kinyarwanda. Those ibihara, it has something like vesicles, not spots. I don't know what they have called it in ibihara in French, in English. But what they know, I don't remember the name, but those they have vesicles, it is like nodule with fluid inside. Whereas this one, neurofibromatosis, it is hard. And those vihara is for children, not for adults. I don't remember the name in English. Ewing's sarcoma. Are you satisfied? Neurofibromatosis, there is no fluid. Whereas those vihara, they have some vesicles, nodule containing fluid inside. So as you see, there is a long list of disease in fibrous tissue, in soft tissue. So it is a subspecialty. That's neurofibromatosis 2. Any question about a soft tissue? Any question?
No.
From Gako, no question?
Yeah, no questions.
So in summary, what you must know, soft tissue can be found in any part of the body, either in the oral, in the cavity, oral, skin, GIT, everywhere. And the diagnosis is made up of by histology. So if there is no question, can have a break and then we resume at 2 with the neuropathology. You see the central nervous system pathology. Okay?
Yes.
Okay. Okay. Thank you. See you at 2 p.m.